Hello, everybody. I would like to welcome you to today's episode of Brain Pet Talks. These talks are supported by the company Positrigo, which is a pioneer in nuclear medicine imaging technologies. Today, the focus will be on brain PET agents in the characterization of neurodegenerative diseases. We are very happy to have Professor Esposito from MedStar Church and University Hospital with us. Professor Esposito is board certified in nuclear medicine and the chief of nuclear medicine and PET-CT and professor of radiology at the MedStar Church and University Hospital. His specialties include PET-CT and SPECT-CT imaging of tumors, cardiac diseases, epilepsy, dementia, and Parkinson's disease. Dr. Esposito is very active in research and in conducting clinical trials. He's also involved in the Professional Society of Nuclear Medicine and Molecular Imaging. He serves as a peer reviewer for multiple medical journals, including Frontiers in Oncology and Frontiers in Cancer Imaging and Diagnosis. Dear Professor Esposito, thank you very much for being with us. The floor is all yours.
Thank you, Stefan. Thank you for Positrigo for allowing me to discuss about the role of PET imaging in the different neurodegenerative processes, right? And what is the role? So the outline of what I'm going to be discussing is, first we'll go over the epidemiology of the neurodegenerative processes, the pathological processes briefly. Then we'll talk about what are the molecular targets that we have currently for PET imaging, and what is eventually then the role of PET in the characterization of the neurodegenerative disease processes. So again, briefly on the epidemiology of dementias, everybody knows how prevalent dementias are and how the prevalence is increasing over time. We have about 55 million worldwide people that suffer from dementia. And the prevalence, if we focus on Alzheimer's disease, the prevalence of Alzheimer's disease increases with age. Obviously, it's a process that's common to all the neurodegenerative processes in a way. So 3% of the people, this is in the United States, are affected by Alzheimer's disease at age between 65 and 74. About 17% in between 75 to 84, and 32% when older than 85. So you can see on the right, with the number of people in the United States as of 2019 suffer from Alzheimer's dementia. And we see, if we sum up the numbers, they are over 5 million people then the United States suffer from Alzheimer's dementia. So very prevalent, and obviously we need tools that allow us to make an early and more accurate diagnosis to try to obviously cope with the disease as best as we can. And I'll show you how PET can be very helpful with that. So we have a number, of course, of neurodegenerative processes. This is a list here. It is not a fully comprehensive list, but these are the most common processes. And obviously, we know about Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. These are probably the most common types of primary neurodegenerative processes. And then the frontotemporal dementia can be classified in different subtypes here. Then we have some dementia that are associated with the movement disorders, and in some of the more rare processes, but some of these neurodegenerative processes are becoming new entities. They have become new entities, and so really the characterization of these diseases is very important, and we'll see how PET again can help with that now as well as in the future. So the neurodegenerative processes, again, just to give some ideas on numbers, of course, Alzheimer's disease is the most prevalent one, and that's the one we will be focusing a little bit more. 60 or 20% of the neurodegenerative diseases are related to Alzheimer's disease, and the mainstay of that is amyloid deposition. At least the earlier of the events that happen with Alzheimer's disease, as we know it now. Cerebrovascular disease-related dementia, 5 to 10%, but most commonly, this presents in association with other processes, and typically with Alzheimer's disease. Lewy body disease, also 5 to 10% of the people suffer from Lewy body disease. And it also, this process is associated with sometimes with Alzheimer's disease related changes. So you can see just from these three most common processes, how there can be some overlap pathologically among the different processes. And so again, it's important to have tools to try to differentiate the different diseases. Then there are mixed diseases that can be up to 50% of the processes can in the end be mixed disease. Often it is Alzheimer's disease combined with other, and these are more prevalent in 85 years of age. And that obviously is intuitive because Alzheimer's disease is more prevalent with age, as well as cerebrovascular disease obviously becomes more prevalent with age. Frontotemporal lobar degeneration, less than 10% of times, is characterized by tau inclusions, and there are some other subvariants of frontotemporal lobar degeneration. And then we see a Parkinson's disease related dementia, which is characterized by the deposition of alpha-synuclein, as also other types of neurodegenerative diseases. So this is a slide that I particularly like, because it illustrates, again, the different possible diseases that we know, the most common ones, the Lewy body dementia, Alzheimer's disease, a part which is mostly a tau deposition related neurodegenerative process, frontotemporal late, again, is a process which is also gives memory problems. But you can see how we have different ways to characterize the diseases, the pathology, right? Amyloid deposition is typically prevalent in Alzheimer's disease and Lewy body dementia, alpha-synuclein also in Lewy body dementia and Parkinson's disease. And you can see how frontotemporal lobar dementia does not really have much of an amyloid deposition. And tau deposition is characteristic of frontotemporal dementia or part disease, but also in Alzheimer's disease. And again, Alzheimer's disease has typically both amyloid and tau deposition. Again, the Lewy body dementia with amyloid, and there is an overlap of amyloid and a synuclein deposition. So again, that illustrates the complexity of the neurodegenerative diseases, how much there can be an overlap in terms of pathology. Again, very important to have biomarkers in vivo that can help us characterize the different disease processes, because obviously they're not the same. The treatment is often not the same. And PET is obviously an excellent in vivo biomarker of these diseases, and we'll go over that. And so we have, with PET, we have amyloid tracers, so we can label the deposition of amyloid. We have FDA-approved tau agent that can, again, show us tau deposition in vivo. And in the future, probably we will have some tracers that label the deposition, the presence of alpha-synuclein. So you can see how most of the diseases can be characterized by PET. In addition, we have the possibility with PET or with the general nuclear medicine studies to characterize dopamine activity in the brain, which can help us differentiate the sum of the diseases. And on top of that, and then we have FDG PET, which is again a marker of neuronal activity and neuronal function. And therefore, this is also a very helpful tool in the characterization of the diseases. So we know that in Alzheimer's, if we focus on Alzheimer's disease, we see and we know that one of the first processes that happens in amyloid in Alzheimer's disease is the deposition of amyloid. So you can see here in this slide that there's a normal, in the normal person, these are the neurons and normal neuronal activity, but as amyloid starts to be deposited, there is dysfunction of these neurons. And importantly, then when tau deposition then later happens, then it's when we start to see neuronal dysfunction. So there are different processes, amyloid deposition and tau deposition, which happen. Amyloid deposition, we believe, happens about 20 years before any cognitive changes. probably more than 20 years before we see any changes in mental abilities. Neuronal dysfunction probably somewhere between 15 to 18 years before any changes, any cognitive changes. We can say in this, we can all be characterized with PET imaging. So in general, we can think of PET imaging as a highly sensitive tool to visualize radio-labeled molecules, radiopharmaceuticals in picomolar quantities. And so we have, again, different radiopharmaceuticals that we can use to visualize the different processes that are underlying the different neurodegenerative diseases. So we have, again, ability to see amyloid deposition, to see tau deposition, and to see neuronal dysfunction and loss. So these are the FDA-approved PET imaging agents. And you can see that there are three, again, in the United States, three of them for amyloid deposition, fluorobetapir, flutamidamol, and fluorobetaben. And then there's one FDA-approved for taucipir. And of course, we know about FDG, which is glucose metabolism agent. Again, these are the FDA-approved ones. And so what is the relationship between what happens in Alzheimer's disease from amyloid deposition, tau deposition, and then a neuronal dysfunction? So this is a normal brain and lateral medial view. So in the red, you can see the areas where there is amyloid deposition, or at least where amyloid deposition starts in Alzheimer's disease, in posterior areas of the brain, the posterior cingulus, precuneus, in the frontal lobes. And then you can see that there is an initial deposition in blue of tau. And then as the disease progresses, there is more extensive deposition of the amyloid. And as the amyloid deposition starts to be more ubiquitous, then the deposition of tau starts to be to increase and extend beyond the initial accumulation that is in medial aspect over the temporal lobe. So it looks like an extensive deposition of amyloid is a process that happens before the deposition of tau. And when tau starts to be deposited in the brain, that's when we start having the cognitive dysfunction. This is a very common slide, a very common figure, but it's very, very helpful to understand the process. So we have, again, here in red, this is a line that shows amyloid deposition. This dotted line shows us the point where we start seeing some cognitive changes. Again, you can see this is where there's no disease pathologically. In about up to 20 years or maybe more, actually, there starts to be accumulation of amyloid, and that starts to build up and starts to build up. Deposition of tau happens only later, a little later. And when the deposition of tau starts to begin, then that's where we have a decline of a neuronal function, neuronal density, neuronal activity. So again, amyloid is the first thing that happens, the first process that happens in Alzheimer's disease. But it's really the deposition of tau that then induces neuronal dysfunction. And all these processes, again, start years and years before we see any cognitive changes, before the patient starts to be actually demented. And then we see that there is a microglial astrocyte activation is index of inflammation in the brain. So again, the opportunity is here. We have many, many years where we can detect the disease before it becomes evident clinically. So the in the National Institute on Aging and the Alzheimer's Association have developed, and scientists have developed in the past, what is the NIA-AA-ATN framework, which is essentially the biological characterization of the neurodegenerative processes, and particularly Alzheimer's disease, with different biomarkers. So amyloid, tau, neurodegeneration. So you can see in this table how the different biomarkers again are aggregated in A for amyloid, and these can be amyloid measured in the CSF, in the cerebrospinal fluid. Currently also can be measured in the blood, but this is not included here. We include only the CSF amyloid because that's the only one FDA approved. Any blood amyloid tests are not approved by the FDA currently. And then we have amyloid PET. And then T4 tau, we have the neurofibrillary tangles, which is it can be seen by measuring activity, the presence of phosphorylated tau in the CSF, and we have tau PET. And then we have markers of neurodegeneration, N stands for neurodegeneration, and we can use PET, FDG PET, MRI, FDG PET, or total tau in the CSF. So this is kind of how we can characterize the disease. So if we go through the different possibilities of combination, again, a normal person, a person that does not have any pathologic processes going on, would be negative for amyloid tau deposition and for any neuronal dysfunction. That early on in Alzheimer's disease, right, when there is really no clinical evidence of the disease, the only abnormality would be the deposition of amyloid. And again, we can see that with a brain PET. And as the disease progresses, then we would eventually have deposition of tau, and that's when the cognitive changes would start, and then we have neuronal dysfunction. So at this point, as the disease advances, we would have amyloid deposition, tau deposition, neuronal dysfunction. This is the situation where you would have some deposition of amyloid, no deposition of tau, and the neuronal dysfunction. So that makes us think that if there is a neuronal dysfunction, cognitive changes without the presence of tau, then that's probably a concomitant Alzheimer's disease pathology with some other non-Alzheimer's pathologic changes that induce the neuronal dysfunction. And then if there's no amyloid deposition, the thought that these are non-Alzheimer's disease pathologic changes, which can be any of the other neurodegenerative processes that we've seen before. And again, all this can be characterized with PET. And if we then put together the cognitive stage of the patient, the cognitive situation with the patient, all the patients with the biomarkers profile, again, we can have different combinations. I'm not going to go over all that, but I want to again point out to the fact that we can supplement what is the cognitive condition of the patient with the biomarker profile and really characterize the disease in terms of how early the disease has, from how long the disease has progressed, and again integrated with the cognitive changes to have a very good picture of what is the situation with the patient and what are the best interventions. So let's switch to actual imaging, and these are the findings with amyloid deposition, right? These are the 3 tracers that have been approved for amyloid imaging by the FDA in the United States. So we have the flutamidamol here, and you can see this is a negative patient, has mostly white matter deposition, which is normal to see amyloid in the white matter, and then a patient that's positive, abnormal for amyloid deposition when there's abundant deposition amyloid in the cortex. Similar pattern for the second tracer that was approved. Again, a white matter prevalently in normal patient and diffuse cortical uptake, gray matter uptake in the patient with abnormal findings. Florbetavir is the same. And then we have here bottom right a tau tracer, the fluorotaucipir. The characteristic abnormality that's more specific for Alzheimer's disease, for example, is the deposition in temporal cortex and the posterolateral temporal and the parietal cortex, as you can see here. So the patient who has no abnormal deposition here and then abnormal deposition here. These are the characteristics of what we see in positive findings for both amyloid and tau deposition. And this is a study that showed they really estimated the following the patient how many years before there's actual clinical evidence of the disease we can see the abnormality with PET. So this is a powerful slide as well. And you can see this is amyloid deposition is one of the tracers that label amyloid. And you can see in this purple color, we can see abnormalities in amyloid deposition in these parts of brain as early 22 years before the actual symptoms are seen. In these areas, about 15 years before. FDG can see abnormalities about anywhere between 10 to 15 years before in both the precuneus and the frontal and temporal region. So again, the first biomarker that becomes positive in Alzheimer's disease, again, amyloid deposition, and then FDG. And then we see thickness here for cortical gray matter thinning, atrophy. And this is something that we can see with MRI, and we can see anywhere between 10 to 15 years to 3 years before. So again, PET imaging amyloid, PET imaging with FDG, and then MRI. So again, pointing to the fact how many years before we can see the abnormality on PET before things happen. And these are cases. This is a patient that has a patient with Alzheimer's disease. We can see abnormality of the position of the amyloid in the frontal areas, in the precuneus, abnormal deposition of tau in the frontal, in the temporal cortex, and decreased of activity in the with the FDG. Typical is in the bilateral-parietal regions as well as in the precuneus here. So this is the typical findings that we see in a patient with Alzheimer's disease. Again, amyloid deposition, abnormal amyloid deposition is the first event, then the tau deposition, and then the abnormalities on FDG. This is a patient with the frontotemporal dementia. They do not have typically abnormal deposition of amyloid, so amyloid is not involved in the frontotemporal dementia process. And you can see that there is no abnormal deposition in the gray matter, right? There can be presence of tau deposition. And typically in these patients, we have a reduced glucose metabolism in the anterior temporal frontal regions in this patient. So you can see the difference between frontotemporal dementia and Alzheimer's disease. This is a healthy patient, no abnormal amyloid deposition, no abnormal tau deposition, normal FDG uptake. And if we add a tracer for dopamine transmission, there is a normal uptake in the caudate and putamen. And this helps us differentiate sometimes Alzheimer's disease from Lewy body disease, for example. And this is the example of Lewy body disease where we can see amyloid deposition, we can see tau deposition, right? This is similar to Alzheimer's disease. We can see reduction of in parietal regions, and characteristically reduction also in the occipital cortex. And the thing that also distinguishes the two, Lewy body disease and Alzheimer's dementia, sometimes is abnormal dopamine activity. So we can see that there is a loss of activity in the posterior aspect of the putamen. Again, helps to differentiate Alzheimer's disease from Lewy body disease. So again, these are all things that PET can help us with. These are all traces we can use with PET. And I'm going to go over some of the appropriate new criteria for imaging with amyloid tracers and tau tracers as developed by the Society of Nuclear Medicine and Molecular Imaging. These are very recent ones. They were recently updated. And the main idea is that the primary neurodegenerative process, PET imaging is indicated when a primary neurodegenerative process is the likely cause of cognitive impairment. But still, etiology, the cause remains uncertain even after a dementia specialist tests in the patient. And also when the knowledge of the presence or absence of amyloid tau pathology, so for example, whether the patient has an Alzheimer's disease process or not, is expected to help establish, again, the cause of the cognitive impairment and to alter the patient management, right? It will be very, very important to know if the patient has early Alzheimer's disease or not. In early diagnosis, again, the PET allows early and more accurate diagnosis. And the early diagnosis is obviously very helpful because it can determine whether the patient is eligible for drug treatment. We know that there have been recently approved a number of anti-amyloid treatments. Again, the presence of amyloid as seen in the brain with PET tells us that there is a target for this anti-amyloid treatment. If there's no amyloid deposition, this patient will not be candidate for anti-amyloid treatment. And also, early diagnosis can help implement appropriate counseling for the patient and family, reduce the need for alternative diagnostic tests. So earlier and more accurate diagnosis allows us to avoid unnecessary testing and testing again and following up until an accurate diagnosis is reached, which sometimes can take years. But with PET, again, we can do that earlier and more accurately. And very, very important, can help us inform decision about patient safety. If we know that a patient has, for example, Alzheimer's disease, then of course, as a family, we will be able to put into place all those mechanisms, safeguards to help the patient. Interestingly, the IDEA study, which was a study conducted by Medicare a few years ago, to see what is the value of amyloid PET imaging, demonstrated that an earlier diagnosis of Alzheimer's disease with PET helped that decrease the number of visits to the emergency room or hospitals. And that's because once you know the patient has Alzheimer's disease, the family would put in place, again, all those measures to again, safeguard the patient, including, for example, trying to help the patient more with the appropriate medication to make sure the patient is actually taking those medications. So the value of early diagnosis, again, the determination of amyloid and tau status is more helpful, of course, in the early stages of impairment. We've seen how early on there is increased amyloid deposition and tau deposition. Obviously, if we can do this test early on in the disease, then that's very helpful. If we do this test late, then that may be not helpful in patients that are already suffering from moderate to severe dementia. Tau positivity is strongly correlated to cognitive symptoms. We know that amyloid PET positivity increases with age, even in patients that do not have cognitive problems. So we need to be aware of that because a positive PET does not necessarily mean that the patient has, at that time, dementia. But importantly, a negative PET, negative amyloid PET, is very helpful to rule out Alzheimer's disease. These are some of the clinical scenarios that the Society of Nuclear Medicine has put out for amyloid and tau imaging. I don't want to spend too much time on this, but I want to give you just the gist of it. And the gist of it is that if a patient is cognitively normal, there's no risk factors, then probably this patient, then amyloid PET and amyloid and tau imaging with PET are probably not appropriate. Certainly, if the patient has subjective cognitive decline, even not tested or not proven by tests, neuropsychological tests, but subjective cognitive decline, and if the patient is at risk for Alzheimer's disease, then the appropriateness of amyloid PET starts to be probably should consider more, and certainly becomes appropriate in patients with mild cognitive impairment or dementia syndrome who are below 65 years of early disease, and in whom Alzheimer's disease is suspected in patients with mild cognitive impairment who are 65 years or older. And again, in any case, when there's mild cognitive changes or subjective changes that are for which Alzheimer's disease is of concern. And we certainly is not appropriate to use PET to make a diagnosis of Alzheimer's disease for non-medical use, legal insurance, and all that. But it is also appropriate to use PET in patients with mild cognitive impairment or dementia, where other tests have been inconclusive, like CSF biomarkers for amyloid or even blood amyloid tests. If they're inconclusive, certainly it's appropriate to use amyloid PET, and also to inform the prognosis of patients presenting with mild cognitive impairment when Alzheimer's disease is suspected. Again, if a patient has mild cognitive changes and we suspect Alzheimer's disease, if we do amyloid PET, then we'll have proof that the patient is likely is suffering from Alzheimer's disease. And also additional tau can help us understand at which point of the progression of the disease the patient is. Is there tau deposition or not? Is the patient soon expected to soon have cognitive changes or not? And certainly, certainly it is very important, amyloid PET these days is important to determine the eligibility for the newly approved anti-amyloid therapies. These are the last few slides. I just want to show you that FDG PET can help also, and it can be very important in the differential diagnosis of dementia. There's certainly different pattern of abnormalities in Alzheimer's disease or Lewy body dementia or frontotemporal dementia, which are again the three most common neurodegenerative processes. As you can see here in Alzheimer's disease, there is a reduction in the parietal cortex and the precuneus. And typically, Lewy body dementia has more involvement in the occipital cortex, which is unique to Lewy body dementia and not as much to Alzheimer's disease. And frontotemporal dementia, as I said earlier, involves more the anterior parts of the brain rather than more the posterior parts as in Alzheimer's disease. So in summary, brain PET in neurodegenerative disease is very helpful in many aspects. Again, we have the possibility to use multiple radiopharmaceuticals to visualize the different metabolic processes that are underlying the pathogenesis of the different neurodegenerative processes, right? So we have the ability to see amyloid deposition, we have the ability to see tau deposition, we have the ability to see if there is any neuronal dysfunction. There are a lot of other PET agents that are being developed in research, and they hold promise to visualize even more pathogenic pathways. For example, the synuclein, alpha-synuclein deposition in the patients with Parkinson's disease dementia or Lewy body dementia. And the combined use of the different agents, again, allows us an earlier and more accurate diagnosis and also better prognostic evaluation of these patients. And in addition, as we know recently, PET imaging allows the selection of the patients for which individualized treatment, so anti-amyloid treatment, is appropriate, and the patient for which anti-amyloid treatments would not work because there's no amyloid deposition. So thank you so much to Stefan for inviting me to present and to pause a video.
Well, we have to thank you. Very interesting insights, obviously. We still have time for a few questions. So if you don't mind, I just bring them forward. You obviously talked about the tracers. Now, which of the ones that you mentioned you feel is the most powerful one or the most beneficial one, if you have to pick one?
Right. So if I had to pick one, it's obviously depends on what is the situation. But if we think that Alzheimer's disease is the most prevalent of the neurodegenerative processes of the causes of dementia, I would want to pick a tracer that allows me an earlier and accurate diagnosis of Alzheimer's disease. So my bet would be on amyloid tracers at this point.
Okay, excellent. Now, obviously, they are all available, the ones you mentioned. Where do you see certain challenges in developing new tracers that we don't know yet? And is there even a need to do that? Do we need additional or new tracers going forward?
Yeah, so there are always obviously challenges in development, but there is a lot of enthusiasm and investment in the PET imaging with these different agents. It's again, the development of the agents is not only helping early diagnosis, better diagnosis, better prognostic evaluation of this patient, but is really helping develop the treatments for the different neurodegenerative processes. So I think it's at least here in the United States, of course, we have challenges that are reimbursement, but I think continued research and continued development is very important to be able to really understand more of the different processes because we still know very little. And it's very important that these PET tracers are there to do research and improve our knowledge.
Of course. Now, a very generic question to probably end this webinar. How and where do you see the role of brain PET in general for the diagnosis of neurodegenerative diseases? Again, there are some other methods out there, blood or fluid biomarkers, for instance. Can they even probably replace PET, brain PET eventually?
Yeah, I think it's very difficult that the test would be able to replace PET. And I think the reason for that, well, of course, there are CSF biomarkers of amyloid deposition. Again, if we stick to Alzheimer's disease, these are the FDA approved ones, but it's an invasive procedure, right? And of course, there are blood-based amyloid tests, which are very important, I think, but they're not FDA approved yet, but eventually they will be, and these are very, very powerful tests. But again, every test has its own limitations, and I think in the end, the accuracy and quantification of PET, the ability to see how the changes occur with the treatments, and proving that actually in the brain there are abnormalities in the brain in a different neurodegenerative process. I think it's very, very important, remains very, very important. So I don't think PET will be replaced, but I think the integration of different studies, PET and non-PET, is very important.
Okay, excellent. Very good. Well, we come to an end. And again, I want to thank you very much for your willingness to share your knowledge here. It was very insightful and very helpful. I would like to thank you for your participation and attendance as well this time. There will be other Brain Pet Talks very soon, so please stay tuned and listen in again when we're going to be back with the next episode of Brain Pet Talks.
Well, thanks you, Stefan. Again, it was a pleasure, and thank you to Prof. Rico. Bye-bye.
Thank you. Bye-bye.